Our next speaker is a native of Canada who's lived in a variety of different countries. He's a certified financial planner, chartered life underwriter, and a registered employee benefits consultant. He has designed health plans and insurance products both in Canada and here in this country. And Mr. Ralph Weber has also written health reform policy for politicians, including Rudy Giuliani and Mike Villines. He left Canada after his wife was crippled by a 2.5-year wait for surgery and after a head trauma received by his son. He now resides in California and works as a financial planner there. He's helped many physician clients in business planning issues, including the analysis of financial statements. And over the years, he's analyzed relative profitability of various third-party payers and has helped some of his physician clients in adapting their practices to free market clinics, like what we just heard here from Dr. Smith. Mr. Ralph Weber will be talking to us about financing free market medicine. Please welcome Mr. Ralph Weber. No steps on this side.
Thank you very much. I feel like I should start by saying, good morning, ladies and gentlemen. I'm a libertarian. Good morning, everybody. I'm very happy to be here. Had some really good conversations yesterday, and it's nice to see some familiar faces. The last presentation was really awesome, but I'll tell you, for an anesthesiologist, he did not put me to sleep. You know, we need to wake up, and shining example of, I think, what we all need to do. As I start off, there's not really much more to add about who I am, but I think it's important that you sort of know who I am and where I come from, why I'm here. I've lived in Thailand, Germany, Nepal, Canada, and the United States. So I've been around. English is my third language. I moved to Thailand when I was about 4 years old. Thailand is a completely, and so is Nepal, a completely free market. It's very open market. Of course, Germany and Canada have socialized medicine. Germany has the oldest system. Canada has one of only two true single-payer healthcare systems in the world. And what that means is that in Canada and North Korea, it is illegal to pay for private treatment. Even in Cuba, you can pay for private treatment, even in Russia. In Canada and North Korea, you cannot. So I've lived in those countries, so I've seen the good, the bad, and the ugly. I am, of course, a certified financial planner, chartered life underwriter. I have a lot of physician clients. Most of them are Canadian physicians that have relocated to the U.S. I help them with cross-border issues and business planning. Most of them, probably 2/3, work for hospitals. But the third that are in their own practice, we work on issues like setting up a free market clinic and looking at profitability, costs, profit and loss statements. As a registered employee benefit consultant, I design free market health plans. And I do this for insurance brokers and agents. I do it for my own clients, some of which are Fortune 1000 companies. I do it for physicians who want their patients to be able to pay on a pre-tax basis, but not subject to managed care. So I spent a lot of time doing that, and I've taken some products that are on the market today that are free market. One great example is a good friend of mine, Dr. Marius Bernard, has invented a product. He invented it back in '83, it's called critical insurance. And what it does is, upon diagnosis of one of 20 critical illnesses, it pays a lump sum, tax-free cash, no strings. Now, it's not meant as a replacement to traditional health insurance, but it is meant to replace a lot of aspects when you have a serious illness in terms of where you can get treatment. I've created a market-based employer group 15 years ago that's still in existence today, completely self-insured, no network, no PPO, no HMO. It is completely free market. It's self-insured. We give back money to the clients every year when they don't use it. and that has been a real success. And that's in Canada, by the way. The reason that I'm here today, and I hope that as we talk, we can identify what the true problem is. Because there's so many people, oh, that red is kind of dark. Can you see the red there? Problems and symptoms. What I want to do is, there's a lot of people that are talking about healthcare reform that are just treating the symptoms. They talk about 47 million uninsured. Well, first of all, there are not 47 million uninsured. And I don't think I have to go into that. I'd be happy to if you like. But there's really between 6 and 9 million uninsured. So when politicians come along and say, we're going to solve the problem of the uninsured by passing a law that forces them to buy something they don't want and can't afford, that's not solving the problem, it's making it worse. When they say, well, the minimum medical loss ratio, for example, in Minnesota it's 82%, California they're talking about 85%, they have one in about 4 or 5 states. When you try to mandate a minimum medical loss ratio, what ends up happening, and it happens each and every single time, the cost goes up. Because if the administration, let's say the average policy is $500 a month, and the administration's $50 a month. If you make that policy cheaper by removing some mandates, maybe by changing the copays, deductibles, make it cheaper. Bring it down to $250. It's still going to cost $50 to administer it, but now that's a 20% overhead. So attacking the overhead, attacking the admin is going to force costs up. Once we identify the problems, then we can talk about some customized, outside of the box solutions. Because what's on the market, the traditional plans that are on the market, for the most part, they're not effective. There's been some introductions lately that have helped, but we can go beyond that. We can go far beyond that. So is our healthcare system broken, wounded, or just mangled? That's what we need to decide, and instead of tearing it all down, we can see what elements of it we can save. So where is the problem? Is it with healthcare? What do we mean when we say healthcare? Financial management of medical care. That's generally what people mean. Or managed care has become mangled care. Or is it medical care? Medical care, of course, is just the treatment of patients. Now we hear people talking about how the system in America is the 37th after Costa Rica, which is ridiculous. People come from all over the world here for treatment. My wife was on a surgical waiting list for 2.5 years in Canada. She needed a bunionectomy. Okay, it wasn't life-threatening, and in Canada, the specialists, actually all physicians, only get paid for so many visits. That's all. After that, they don't get paid. So most of the specialists shut down their clinic in September, October. They've seen their quota. They can't charge cash, so they leave for the winter. Of course, you can't get to see a specialist without going through your primary care physician, and 16.8% of Canadians don't have a primary care physician. In Quebec, it's about 30%. So trying to see a specialist is hard enough. That's going to take you probably half a year. Once you get to see one, getting in is going to be even harder. So she waited for 2.5 years, and her bunion got worse and worse. She moved from a cane to a walker to Vicodin. And she could barely walk. She used to be a runner. She couldn't run. She started gaining weight, and she was practically crippled when we got to California. The first thing we did is we went to see an orthopedic surgeon, and we knew what the problem was. We knew what had to be done. We went to see the orthopedic surgeon, and my wife said, listen, I just need this taken care of. And he said, okay, well, do you want to talk about, no, I just want to get it done. When can you do it? How about day after tomorrow? Great. We went to the hospital, and I asked, how much is this going to cost? And they said, well, it depends on what kind of insurance you have. And I said, well, I don't recall saying that I have insurance. I asked how much it's going to cost. And they said, well, depends on what kind of insurance you have. And I said, what part of this don't you understand? I didn't say that I had insurance. But tell me what you mean. And they said, well, for example, if you had Blue Cross, it would be $22,000 for the facility charge. And I said, okay, well, like I said, I didn't say that I had insurance. And he says, well, if you were uninsured, we could give you the cash rate. And I said, what's that? $1,299, $1,300. So I pulled out my checkbook and I said, okay, who do I make this out to? I paid for it right then and there. $22,000 versus $1,300. But the problem was fixed. With my son, he suffered a head trauma. He was hit head-on by a car on his bicycle with no helmet. Took 4 hours, and he got an X-ray and was discharged. No CT. No, it wasn't available. The closest CT machine. We lived in Niagara Falls, Ontario, which is a city of permanent population of 75,000. There's a city 15 minutes away with 130,000. No CT. Closest one was in Toronto, which was 130 miles away. And there was a waiting list. So no CT, just X-ray and discharged after 4 hours. And that was enough for me. That's when I decided to leave. That was sort of, what closed the deal for me. But when we look at solutions, there's so many people that look at Canada romantically. Oh, well, everybody's covered. Well, no, actually, 2.5% to 5% of Canadians are uninsured. And nobody's talking about that. And the uninsured in Canada, different than the US. In the US, if you present at ER, they have to treat you. In Canada, they do not, unless it's life-threatening. If you go and you're unconscious, of course they'll treat you. But they don't have to treat you if you're uninsured. So what are the possible solutions? Government medicine. And I think most of you have had experience with Medicare or Medicaid. And really, that's a small example of what it would be like. If anybody really wants government medicine, then I think what they should do is for a year, drop insurance and cash and just take Medicare and or Medicaid and then try it out. There's a lot of people that, and I talk to groups of doctors all the time. Once in a while, there's people that say, oh, yeah, we need, government medicine because they're not for profit and, they're gonna solve all these problems. And it's not the case. It's not the case. You have to live it. On paper, it looks fine, but it doesn't work. It never has, never will. Then there's the status quo. It's better than government medicine, but I don't think it's working that well. Or there are free market solutions. Now, what do we have now? What kind of I'm sorry? A mixture, yeah, it's a mixture. We've got some government medicine. We've got some managed care. We've got a little bit of free market. And actually, we have the pieces that we can put together free market. We can do that right now. We don't need to wait for politicians to change laws. We could do that right now. What we've got is, I think I'm preaching to the converted here. We all know we have price fixing by CMS, restricted competition. We all know that. We've got a payer. Now, this is really interesting. Anybody in here an attorney? There is. Okay. We have a payer system which defines contract law, and the next slide we're going to talk about that a little bit. Eroding doctor-patient relationship. Yes? Administrative waste by micromanaged small claims. And, of course, we're moving towards cookbook medicine. At least that's what the managed care outfits want. So let's look at the contract. First, you have the patient. And then you have the payer, third-party payer. There exists a contract between the payer and the patient, which is called a unilateral contract. What that means is that the patient or the insured at any time can stop paying. They're not contractually obligated to pay their premium. They can stop at any time. They don't have any responsibilities. However, the payer has a one-way unilateral responsibility to the patient. Then we have the provider, doctor, hospital, pharmaceutical. And between the provider and the payer, there's a bilateral contract. Now, what's interesting is the lack of any sort of contractual relationship between the patient and the provider. Okay, so when I talk to attorneys, this is sort of our starting point, because they like to visualize contractually where some of the problem lies, and this is some of the problem. Another one that comes from this is patient confidentiality. How many people have contracts with insurance companies? Good, a few, not that many. This is a standard clause within an insurance contract. The provider shall readily make available to the insurer, the department, and HCFA, and any other government agency with regulatory authority, medical and health records of beneficiaries receiving contracted services and all related administrative records. Now, when I got to California, the first thing I looked for in my own personal physician, and as I said, I've got a lot of clients that are physicians, none in my area. So I wanted somebody that didn't accept Medicaid, didn't accept Medicare, and did not accept private insurance. And there was only one in the north part of San Luis Obispo County that fit all those criteria. I didn't want somebody that's going to cost shift from Medicaid and Medicare. I didn't want somebody that took private insurance, because I want my, as a patient, I want my confidentiality honored. I've got probably 6,500 people that we insure, our company insures for health, and we tell every single one, when you're looking, the ones that have the free market solutions, we tell every single one, when you're looking for a physician, you have to look for somebody that will accept cash payment. Because, you know, if you want your confidentiality, you know, go and pay cash. Don't use your card. Don't look for network providers. So what don't we want? And sometimes when we talk about the system that we have and how much we dislike it, the natural thing is, well, maybe we want government medicine. Okay, now, you all know this quote: the government is not the solution to our problems, the government is the problem. They've created this with the legislators. Although we don't have a free market now, we can build it. The pieces are there. We can put it together with the products that are on the market right now. I've created, one of the free market solutions is adaptive healthcare. Completely free market. No network, no discounts, no providers. Next month I'm going to Bangkok, Thailand, which is where I grew up, meeting with a hospital there, CEO of a hospital. We'll send our patients, and you know, I'm hoping that this weekend I can find some other people that want to see some of my insured clients and offer them cash deals, just like Dr. Smith was talking about. But right now we've started sending our patients, you know, outsourced, instead of dealing with the PPOs and the price fixing. What defines a free market? What defines a free market? Does anybody have any idea? Okay. This is the definition. A free market is a market in which property rights are voluntarily exchanged at a price arranged completely by the mutual consent of sellers and buyers. Does that sound right? Is that what we have now? No. Here's the second part. By definition, in a free market environment, buyers and sellers do not coerce each other in the sense that they obtain each other's property without the use of physical force, threat of physical force, or fraud, nor is the transfer coerced by a third party. Okay, so we don't have that. We don't have that. So when people talk about free market solutions, they're not talking about the status quo, because we don't have a free market. Now, here's the interesting thing. We did a survey with Jane's help through AAPS, and some of you remember receiving this survey. Some of you responded. Altogether, we had about 75 responses to the survey that we sent out. We wanted to find out what people's mix was of revenue. The results were very interesting. The average medical practice we found had 3 medical doctors, 2.5 other medical staff, 5 non-medical staff, and 1 administrative staff. Now, there's more than half of the staff are non-medical. So that really doesn't make a whole lot of sense, because the non-medical staff, they don't generate revenue. The non-medical, they're overhead. Yeah, yes, we need some, but they're not generating revenue. So why are there so many non-medical staff? The extrapolated revenue was about $1.4 million for this typical clinic with 3 doctors. Some of the respondents took Medicare, some didn't, some took Medicaid, some didn't, and so on and so forth. But we compiled the results to try to get a bit of a picture of where the revenue was coming from. So first of all, for Medicaid, the typical clinic, and I tried to assemble it as one typical clinic, had about 1,650 patients that were Medicaid patients. They had total visits of about 600 per year, which is 0.36 visits per patient per year. That seemed kind of low. But when we looked into it closer, we realized that Medicaid patient, they're on Medicaid 1 month and then they're off, they qualify, they disqualify, and they move around a lot. Okay, so they had a low visits per year. Payments were $49,000. Payments per visit were $82, but the revenue per patient was only $30 a year per Medicaid patient. Then we looked at Medicare, 1,277 patients, and they had 2,300 visits per year. Visits per patient were almost 2. Payments, $203,000. Payment per visit, $86, tiny bit higher than Medicaid, but not a whole lot. And revenue per patient, $165 per patient per year. So a little bit more revenue from Medicare. And then we looked at private insurance patients. But by far, this was the largest segment with 8,500 patients and 6,800 visits per year. Ratio of 0.8 visits per patient per year. Payments of just under $1 million, payment per visit 144, up from 83 and 86. Okay. And of course, the revenue per patient was 116. The last category was cash pay. And because this survey was AAPS members, not just the general, physicians, I think we skewed a little bit higher than the average would have, but it's still lower than I was hoping for. 846 patients, total visits of 1,200. Visits per patient per year, 1.5. Payments about 190,000. Payment per visit 156. And revenue per patient 223. So we saw really clearly that there was more revenue and naturally less overhead. So if we look at the total of Medicare, Medicaid, cash, and insurance, we have 12,300 patients in this typical clinic with 3 doctors, 2.5 medical staff, 5 non-medical, and 1 admin. Total visits of 11,000, visits per patient 0.9. Here's the 1.4 million. Payment per visit, average was $130. With the cash pay and the insurance subsidizing, of course, the Medicaid. Revenue per patient, $117. Does that look close to what you're seeing out there in your own practice? Yeah, okay. Then we did a different survey of completely free market clinics with no third-party payers involved. 3 doctors, 5 medical staff, 2 non-medical, and half of an admin staff in the typical clinic. Extrapolated revenue, $2.6 million. It's almost double. Why? Well, because the other medical staff are bringing in some revenue by, doing other kinds of visits. They're bringing in the revenue. The admin staff, they don't bring in revenue. So let's look at this side by side. The average practice and a free market practice. 3 MDs, 3 doctors, 2.5 medical staff, 5 medical staff, 5 non-medical, 2 non-medical, 1 admin, half an admin. Revenue is 1.4 versus 2.6 million. Big difference. Same size clinic. Now, does anybody want to guess where I found these free market clinics? AAPS? That's a good guess, except because their GDP is 1/10 of ours, that would be a little bit high. Good guess, though, because that is a free market. Yes, sir. I'm sorry, Nepal? No. I'm sorry? No, there's no free market in Canada. There's no market. I'm sorry? Well, Brian Day is working really hard. I like Brian Day, and he's kind of gone a little bit under the radar since he's become the president of CMA. But he'll come out fighting when he's done. Well, here's what I found. Okay. Oh wait, I've got some more results here. Patients, visits per patient 1.5. Okay, which is where we get the revenue from. Revenue per patient was $200. Okay, I'm going to keep you in a little bit of suspense before I tell you where it came from. So comparing the free market on the left, the typical, and these were AAPS members, and on the right was the free market. Patients, it's almost the same, 12,300, 13,400. Visits, 11,000, 20,000, more visits. Visits per patient, 0.9 versus 1.5. Payments, look at that. Revenue per patient, almost double, okay, in the free market clinic. There we go. The free market clinic. Can you think of anything more free market in medicine than the veterinary community? There's no third-party payers, okay? These results were supplied by the American Association of Veterinary Medicine, okay? And this is what we spend on our dogs compared to what the third-party payers allow us to spend on ourselves. So, is anybody surprised by that, by the way? Nobody's surprised? Okay. Where's the waste in our current system? I hear people all the time saying, well, if the government takes over, Medicare administration's only 2.5%. So and private insurance is 30, 40, 50. Of course, every time you hear it's like the fish story, it gets bigger. So the government needs to take over because it's more compassionate and more efficient. Well, I saw that sticker out about FEMA. If you like FEMA, you'll love socialized medicine. We know the government is not more efficient. The problem with our system is when so many small claims are micromanaged, it costs a lot of money. It costs about the same to process a $100 claim as a $10,000 claim. Once you get to a $200,000-300,000, there might be a kind of a second opinion. So the admin might go up a little bit for that. But 85% of all medical claims are under $100, and it costs on average $55 to process a medical claim. So to pay $100 costs $155. That's a lot of waste. That's a lot of waste. And of course, there's the cost of buying the CPT codes. Okay, the entity that makes these CPT codes and sells them, they're making money. Okay, but that's another cost of admin that you have to bear. let's look at the admin costs as they exist right now. And actually, I'd like to change the word administration to overhead. Okay, Medicare has about 12% overhead. Okay, 12% doesn't sound too bad, but that's 12% of $16,000. So that's pretty high. Medicaid, of course, has about 31%. Private insurance has 14%, and that includes premium tax of about 2.5%. And when people see this data in isolation, 14 versus 12, well, even if they say, oh, well, that's great, then let's move to the government. 14% of 3,400 is a whole lot less than 12% of 16,000. And we know that if it went to the government, it wouldn't be 12% of 3,400. So the tremendous waste that exists is the waste from micromanaging all these small claims. It's all the small claims. It's not the big claims, okay? One of the, there's 6 priorities that I have in healthcare reform. The first one is I think we need to restore the doctor-patient relationship. Everybody agree? Thank you. Number 2, we need to restore the principles of insurance. Sorry? Catastrophic, exactly. Our healthcare plans, they aren't insurance plans. They're prepaid healthcare, okay? And it's just, insurance is not an efficient way to pay for routine costs, which are known in advance. It's just not efficient, because you have to add $55 onto every $100 that you use to pay that 100. Number 3, we need to remove third-party payers from routine care, but allow pre-tax funding of medical expenses. Number 4, we need transparency in hospital and provider billing and require rates be clearly posted. I'm sure that the story, about my wife in the hospital, I'm sure that wasn't unfamiliar territory. I'm sure you've all seen that yourselves. Same thing when you get a prescription filled. They can't tell you the price. Well, what insurance do you have? What should it matter? I mean, I don't have a problem with maybe giving Blue Cross 5% discount because they bring more clients. I don't have a problem with that. But in what other industry in America can you go in where there's no prices posted? You know what they say about restaurants, if there's no prices, you probably can't afford it, okay? When you go to the shop to get your car fixed, it says labor rate, $95. It's clearly posted. When you call your plumber, $95 for a service call. It's transparent, that you know exactly what you're getting. But because we've been isolated from the true prices, we don't think about what we consume, and we overconsume. Number 5, we need to remove government-imposed barriers to free market competition. Is there anybody that disagrees with any of these points? Okay. So now I said 6 and there was only 5, but they say that there's 3 kinds of economists, those that can count and those that can't. The principles of insurance. Insurance it's a transfer of risk tool, okay? Insurance is meant to transfer risk, and what it does is risk of loss. It's meant to transfer risk of loss when the occurrences are infrequent, but the size are large, catastrophic, okay? That's what insurance is meant to do. When insurance covers risk where the winners and losers are known in advance, okay? When insurance is trying to cover a risk that's known in advance, where the winners and losers are known, that's unsystematic risk transference. And I'm sorry, when the winners and losers are not known in advance, this is unsystematic risk transfer, and it's very, very efficient. When the winners and losers are known in advance, then this is systematic risk, and it's transfer of wealth. It's wealth risk redistribution socialism. Okay? When the winners and losers are known in advance, then it's very inefficient. And this is what our medical system with managed care has attempted to do. They've attempted to make a plan where the winners and losers are known in advance. And when you go to a company with 10 people and they have 3 different plans to choose from, you know, the ones that think they're going to use it a lot, they're going to get the lower copay. So they know in advance that they're going to use it. And they think that money grows on insurance trees. So they get the plan with the low copay, and then they use it. Oops. So how do you set up a free market clinic? The first thing that you have to do is you have to decide what is your competitive advantage. What are some examples of competitive advantages that you could have? Price, timely access, privacy, better product, more time with the patient, less headaches, absolutely. I'm sorry? Happier staff. And more medical staff and less overhead. Okay? There's concierge practices. Okay? And some, you know, SIMPD has a lot of members that have concierge practices. House calls. One of my clients up in actually, no, he's not a client. He's a friend of mine in San Francisco, sfoncall.com, Jordan Schlane. He built a practice. Now, mind you, it is San Francisco, okay? But what's important is that it's in a larger city. You probably can't do this in a small town. He does all house calls. And every 6 months, he adds another doctor. He's got 3 places now. He's got San Francisco, Marin County, and Palm Desert. Okay, sfoncall.com. Check it out. He has his prices clearly posted, and he has all the rationale why you should pay to use his practice versus, you know, the PPO doctor. Great business. Mall medicine, you know, there's some people that say, well, I'm going to have a sort of a mini clinic, which I'm going to oversee, and maybe put a nurse practitioner. That, you know, Walmart has kind of done a little bit of this, you know, just for boo-boos and strep throat kind of thing. You know, can be an offshoot if it's supervised properly. I have a few clients that consult with their patients by phone, internet, and webcam. Okay, not as a primary treatment source, but, you know, as a follow-up. Some of the concierge practices do this. They give their clients a webcam, and they say, listen, if you got something wrong, make an appointment, and we'll talk. And then they've got this little webcam, and they say, oh, I've got this rash, you know, and then, you know, they can show it on the webcam. So that's another thing that has worked. Wellness care rather than disease care. The current medical system, it's really a disease management. It's a symptom treatment program, okay? So a lot of doctors that I know have really added wellness care. More time with patients and confidentiality. Those were thrown out earlier. So I think we need to bring back Dr. Marcus Welby. You know, that's what we need to do, because in those days, practicing medicine was practicing medicine, and it was between the patient and the doctor, not the third-party payer. So moving to a free market clinic, start by examining your revenue mix, okay? I've done the survey, and Jane, I'll give you these slides, and I'll give you these results. You can post it so that everybody can see it. Look at your own revenue mix. It's a big job. It's hard to do that, but if you want to move to free market medicine, it's a great starting point. Because then what you can do is you can find out what part of your business is most profitable, which is least profitable. And it's not just the revenue, it's the overhead. How much work do you have to do to put through a claim? Of course, you know, drawing up a business plan, I work with a lot of my friends and clients on this to develop goals and slowly spin off, get rid of the unprofitable business. And if that's Medicaid, or if that's one insurance company, maybe United Healthcare, maybe you're only seeing, you know, 50 patients a year. So get rid of that, okay? If it's not profitable, spin it off. Cash prices. Now, how many people here have cash prices? How many people have them clearly posted, whether it's in the internet, office, on a brochure? Okay. How many of you have cash prices that are lower than the typical insurance price? Great, very good. Because there is less admin, right? Exactly. There's no accounts receivable. You get the money at the time, you know. How about passive income? How many of your clinics have passive income? Okay. Passive income is really important, and I'm sure you all know what that means. You know, if you own your clinic and rent out, you know, the second store to, you know, somebody else, an accountant, an attorney, whatever. So you have some passive income by owning your building. That's going to generate some passive income right there. Some of the wellness clinics that I've seen, they have ongoing income. It's not just fee for service, it's ongoing. Concierge practices, of course, it's not really passive income, but it's ongoing income. Some clinics that I've talked to, they'll have, you know, a few MDs, and one of them will do Medicare and cash, and the other one will do Medicaid and insurance and cash, but they divide it up so that, you know, with the Medicare thing, of course, you can't balance bill. But if you say, well, you know, because I'm a Medicare provider, I can't do this, but here's another doctor that's a cash-only doctor. So there's ways of sort of moving business back and forth, doing that way. Cash rates, of course, you know, I think that we've discovered that for the most part they reflect that the administrative costs are less. And other medical staff can perform revenue-generating activities. In the example, you know, with the veterinary offices, of course, that revenue was, you know, clipping dogs' toenails and stuff like that, maybe, you know, or other kinds of things that an administrative, and of course, you might not want to clip people's toenails, but if you've got, you know, nurse practitioners or PAs or something, there's some other activities that maybe they can perform. And if they can't, well, then maybe you don't need them, other than to assist you. Adding value. Cash is king. Absolutely. Nothing like it. Jordan Schlane, SF On Call, doesn't take insurance, Medicare, Medicaid. As a matter of fact, he doesn't even take cash, Visa and MasterCard only. Okay, he actually does not take cash. Just because he's out, you know, and he's got a small EKG machine, he dispenses the medication at the time of service. Actually, it's a lot like a veterinary clinic. So, you know, these kinds of things are going to add value to your clients. Okay, and there's so many shining examples of it. There's the wellness clinics, there's the on-call, there's the, you know, the third-party payers, they want cookbook medicine. They want something that they can manage. They want to define what that medicine is. And trust me, it is worse in a country that has socialized medicine. Cash clients. Now, remember the survey when we talked about the number of visits per year? Those that paid cash had more visits per year. Okay. Why do you suppose that is? Service. They're getting good service. They see the value. And when you're insured by Blue Cross tells you whether you can see Dr. Smith or Dr. Jones. Okay? And people change jobs all the time. They get different networks. With cash, there is no network. You find a doctor that you trust, that you like, that you believe in, and you stay with that doctor. Healthcare rather than illness treatment. Okay? So the market, what is the market for free market medicine? Self-funded patients. And I think it was, Ken, was it you that said you prefer to call it self-funded, not uninsured, right? Self-insured. Okay, self-insured, self-funded. You know, when we talk about uninsured, then we have people making ads that say, oh, there's 1.85 million bankruptcies due to medical bills, which is complete baloney. Absolutely incorrect. There's no study that backs that up. Completely false information. Doesn't happen. Okay? There are a lot of bankruptcies due to medical reasons, such as lost income during a lengthy illness, which is why Dr. Bernard invented critical insurance. But medical bankruptcies due to medical bills are actually very, very, very low. This is a huge market. This is a huge market. Everybody knows what an HSA is, right? How about an HRA? How many people have never heard of an HRA? Okay. HRA means a health reimbursement arrangement. It's a self-funded plan set up by an employer. They don't need to, HSA has to go with a certain kind of insurance plan. HRA doesn't. You can have a standalone HRA. As an employer, you can say to your employees, okay, every one of you, I'm going to allow you to spend $1,000 a year or $5,000 a year, or whatever. The employer can define the amount, and they can define it's for prescriptions, it's for office visits, or they can get a high deductible plan and say, for the first $5,000, I'm going to reimburse you for health expenses. Now, between HSAs and HRAs, right now, as of now, we have 15 million people in America, 5% of the population that are covered by HSAs and HRAs. That has grown by 40% in the last year. A year ago, we had about just under 11 million. And they're expecting another 40% growth this year. So this is a huge market. This is a huge market. This is a market that I talk to about most of my insurance clients. And I tell them, you don't need to go to a network provider because 80% of Americans spend less than $1,000 a year in healthcare, in medical care. 80% of Americans spend less than $1,000 a year in medical care. My own I mean, all of the medical needs I've had in the last 3 years, I've paid through my HSA. I didn't even look in network, out of network. I don't care. Doesn't faze me. When our clients call, and if they need some elective surgery, we'll call for them. We'll negotiate. And hopefully we can call a lot of you people here today and say, listen, I've got a patient. They need such and such. It's going to be paid direct by the employer. So HSAs and HRAs are a great market. And of course, those who want convenience or value, tired of changing providers. Okay. So this is just really sort of a recap. Are there any questions that anybody has? Yes, sir.
One I wanted to point out just before you leave it is the fact that we have to be careful about HSAs. I found that out the hard way. Our own state medical association has an arrangement with one of the big players. And in it, they have an established fee schedule. When I signed up for it, I didn't realize that. I came to find out when I needed medical care myself. And then when I had a bill for an x-ray, I found out that the hospital outpatient center charged about 5 times as much. So I'm a member of this panel. It's the only HMO that I have. And I called and I said, I need to find a price. And I'm thinking of putting an x-ray facility in my office, which I wasn't. But I said, I'd like to know what you would charge for a spine x-ray and both knees. And the answer was, what would you pay? That is, the HMO pay me for doing it in my office. And the answer was $135 for everything. Uh-huh. My bill was $740 for my wife to have the same 3 things, and it was charged out as a CAT scan. I went to the hospital administrator and I said, this is wrong, this is fraudulent. Uh-huh. And I got no benefit from that, but the insurance company was willing to pay $540 for those same services. Now that came out of my HSA. Mm-hmm. I had no control over that plan. Mm-hmm. So I think that when we talk about HSAs, it's a real risk because in Minnesota, and I think Twyla probably knows about that, I think it's the Blues have actually, the experience is that HSAs have not saved money because they're using that product to reimburse their HMO losses. And so they find that it's been negligible, the difference. Right. It's a real important difference.
You're right. In Minnesota, I've heard of that happening. I've heard of that happening. Doesn't happen in every state. Is there anything that would prevent me from coming to you and saying, I just want to have a regular office visit, and I've got an HSA, how much is your charge? And you could say $50. We could have that transaction, right? So HSAs can be used, and we need that consumerism, and a growth of 40% a year, we're going to get that. We as insurance people, as payers, as providers, as doctors, we need to help educate the people that you don't have to be a victim of this price game, this price fixing thing. You don't need to be a victim of that anymore.
Yeah, there's another part of the story. The two things I did was I sent a letter to the Ohio Department of Health and also the Department of Insurance. I got no satisfaction at all. I talked to a colleague of Ken and mine, who's the president-elect of the Ohio State Medical Association, and I told him the story, and it went nowhere because the medical association, the state medical association, is actually, pardon my word, screwing its own members, because those people who have outpatient facilities are getting defrauded by the big institution. Now there's a second part. Is there can you expand on the explanation when you said there aren't 40 million uninsured, there are only 9?
Right.
What's your reference for that?
Well, the latest official number from the Census Bureau is 45.3 million. 42% of those are eligible for Medicare or Medicaid. They just haven't filled out the government paperwork. Okay? So we can call them uninsured, but at the time of treatment, one signature and they're covered. Okay? So that's almost half of the 45 million right there. Then there are a number which are the second large number, they're between jobs. Now you know that you've got 63 days to exercise your COBRA. Most people, they wait until the 62nd day. So technically they're uninsured for 62 days, but if they need it, they can sign. So the vast majority of those 45 million fit into those two categories. And then beyond that, there's the voluntarily uninsured. And those are, as Ken says, the self-insured. And those people have just chosen. They can afford health insurance. They could buy it. They could qualify. They could afford it. They've just chosen not to because they don't think it's a good deal.